Welcome, everybody. My name is Alan Roth, and I'm a practicing family doc, chair of family medicine in Queens, New York, and a proud member of the board of Primary Care for All Americans. On behalf of the board, I want to extend a warm welcome to you all and for tonight's Zoom teach-in session. Thank you for joining us. We now have over 1,200 people from 40 states, the District of Columbia, more than 350 zip codes, and we are reminded of the incredible momentum we've been building to develop and advance primary care for all Americans. This growing movement to provide primary care to everyone continues to spread, fueled by your dedication and your commitment to us. Speaking of growth, community building and storytelling are the heart of expanding both our organization and the access to primary care for all. Tonight, I'm thrilled that we have the opportunity to learn from Allison Warfel about how to effectively share the story of your community. Before we get started, I would like to extend my sincere thanks to all the presenters for tonight's event. I also want to thank the Primary Care for All Americans Zoom committee, as well as John Wright, Brian Kaiser, Patty Armstrong, and Liv Veretti for organizing this event. Please take a moment to share where you are joining us from in the chat so we can see who's where as we work together to build this movement. And as we do, let's refrain from using professional titles. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas and commitments that will ultimately drive this movement forward. Now it is my pleasure to introduce our keynote speaker, Allison Warfel. Allison was born and raised on Block Island and is the Chief Operating Officer at Block Island Health Services. She has worked in a variety of healthcare settings, including sports medicine, performance, healthcare administration and primary care, and higher education. Allison is passionate about increasing access to healthcare in rural and underserved communities. Tonight, we are here to both teach and learn from each other. We encourage you to contribute by submitting your questions in the chat throughout the session. Please stay with us at the end of the session, where we'll have time for Q&A sessions and a hopefully lively discussion. We'll be exploring how you could bring primary care to everyone in your own neighborhood and community. Now, without further ado, let's dive into tonight's topic. Take it away, Allison.
Thank you so much, Alan. Let me get my slideshow up here. All right. Thank you, everybody. Good evening. Thank you so much for having me. Tonight, I want to tell you a story about a community that means a lot to me. Block Island is an island that's 7 miles by 3 miles, and it's 13 miles off the coast of Rhode Island. There is no bridge. There is no tunnel. We are accessible only by boat and by plane. If you've heard of Block Island before, it's probably because of our status as a go-to vacation destination. However, today I want to tell you about a different Block Island. This Block Island has rolling hills and picturesque stone walls and this incredible way that the light and the sky kind of come together. This is a place that people have come for years to rest and recover and rejuvenate, and at least one time that we know of, hide out from the FBI. However, the people I want to focus on today are the year-round residents of Block Island, who have a long history of advocating for their healthcare, a tradition we are trying to keep alive today. In the 1960s, Block Island had a single doctor who would travel around and make house calls. Around that same time, the state of Rhode Island decided to help out by sending a visiting nurse named Mary Donnelly. Mary D, as she was later called, is and was an absolute legend, and she remained visiting on the island until her death in 2022. If you talk to islanders who were around during the early days, the 60s, they'll tell you that they got by, but you had to be tough. In the 70s, in an effort to attract a doctor to the island, the town purchased an old ship captain's house and renovated it so that on the ground floor, there was a small waiting room and 2 exam rooms, and the doctor could live upstairs. Now, the doctor was on call all the time, but he had 1 day off a week. And if he happened to leave the island, ambulances would simply wait in the driveway for him to come back. In 1979, the community got together to raise money and to build the facility that, as Mary Donnelly put it in many community meetings, we deserved. It took 10 years, but in 1989, the Block Island Medical Center finally opened. And this facility, as you see it right here, has served the island for 36 years, up until this year. By 2017, it was clear that we probably needed to make some changes. So this facility, which was built with everybody in mind, still had to wrestle with some very, very difficult questions. Who are we? Who do we serve? Do we put our resources toward our 1,000 year-round residents or toward the million people that come and visit us in the summer? How do we stay sustainable? How do we attract providers and staff? So when we decided that we needed to probably do something, when we decided it was time we needed to think about a new facility, we embarked on a new construction project. And through lots of conversation, both inside and outside our organization, we started defining ourselves. We practiced our narrative. We got comfortable telling our story to ourselves, to our community, to our donors, and eventually to our representatives at both the state and the federal level. Through this process, we decided we are rural. And for a lot of you on this call, you're saying, well, that's obvious. But actually, for us, it wasn't. We didn't understand what being rural meant in the medical world. And we decided to become a rural health clinic in 2023. And this was as much to solidify our identity to the outside world as it was to try to become more financially solvent. After all, when you talk about being a medical center to a mainland provider, they're picturing something quite different than what's actually happening on the ground. This also made it more clear to us what sort of grant opportunities we might actually be able to apply for. We wanted to be primary care minded. So while we understood that we could not leave urgent care behind, this was a service that the island really needed from us, we identified an opportunity to lean into primary care, which, as it turns out, when you compare that in urgent care, at least for us, it was a better financial decision. But more than that, it actually allowed us to lean into our values and take much better care of our community more holistically. We are a rural workforce training site. We have a long history of having Brown medical students and hosting a family and emergency medicine elective. However, it's not something we really talked about a lot. So students were coming for more like an island vacation than for learning about rural medicine. So we decided to expand this. We wanted to bring students out who are NPs and PAs, but we also wanted to lead with our rural identity. We weren't just training folks for a unique experience. We were training them in rural medicine, and we were training them for our community and for communities who are like ours. We also decided we had to be integrated. We had to lean into what our community wanted from us, even when it was difficult to figure out how to do it financially or logistically. They wanted behavioral health. They wanted more dental. They wanted hospice care and care at home. These talking points helped convince our donors to give us money, our congressional representatives to advocate for us, and our community to get behind our project. Our new facility, which is actually open right now, but we're finishing up some details, so it should be fully open later this month, reflects this identity. We have housing for our rural health elective. We have a new dental suite. We have a behavioral health room that's set up for in-person or telehealth services. And we have room for primary care to continue year-round, even in the summer when our visits expand and go up exponentially. We feel like we're on the precipice of something that's truly exciting. So I want to pause here for a moment and just ask you to think, how did my story make you feel? Now, Primary Care for All Americans has an excellent playbook that I highly recommend, but here are just some nuggets that I have learned about this. So our experience taught me a lot. Number one, own your own narrative. People are always going to tell you who you are and what you are to them, but only you can really decide who you are as an organization. So gather your stakeholders together and do the hard work of figuring that out for yourselves. Be authentic. People can tell whether or not you believe your own story. Make sure you actually feel it. Data is awesome. I love data, and it certainly has its place. But when you're telling your story, your goal is the warm fuzzies. People need to feel it. They want to be a part of a movement that makes them feel inspired. Focus on what you do for those that you serve. Focus on how you live into your values as an organization. These are the things that are really going to bring people on side. And finally, be realistic because we don't want to overpromise and underdeliver. But at the same time, when we get stuck in that scarcity mindset, we set a ceiling for what we can accomplish. And that probably is a false ceiling. We can probably go higher than that. So avoid the scarcity mindset for that reason, but also because it doesn't make for a very good story. Thank you very much.
You're muted.
Thank, thank you. Thank you, Allison, and thank you for your wonderful story. That was really great and warming, and truly is what we would call medicine in America. So, if anyone has any questions for our keynote speaker, please post it in the chat so we could answer your questions. By joining and learning how communities can provide primary care to everyone and bringing one new patient or more each week, we are going to build this movement together. Our work groups need more people to roll up their sleeves and be part of the work we're doing. Please click the volunteer button or the contact us section of the website and tell us how we could help you or you could help us. Together, we can make sure that everyone in the United States receives equal health care and gets equal health, regardless of where you live, how much you earn, what community you come from, or what you look like. Patty?
Thank you so much, Alan. All right, we're ready for questions. I haven't seen any pop into the chat yet, but please feel free to add those in. I do have a couple of questions for you myself, Allison. So I think one of the big things that we've been really trying to learn about that you just did such a beautiful job of is telling your community's story. And I think as we try to figure out sort of what are those hooks that other communities can use to get people involved or feel that the warmth that I think I saw someone mention before too, to get everyone in their communities really passionate, sort of what you guys have done.
Yeah, so I think a lot of it just starts with what is it that makes your community your community? What is it that makes you proud to be from there? I think Block Island has a very rich history and a rich story and sort of like an ethos about it, but that's not unique to Block Island. Many communities have that. So I would say kind of go back to that. If you already have a facility, go back into the archive, find those pictures and kind of start talking about like, how'd you get here? Like, whose idea was this in the first place? To really get to know your history, where you came from.
Yeah, actually, as a follow-up to that, Lynn, do you mind coming off mute and just asking your question here about sort of the process?
Sorry, there was I could hear something going on outside my house and I just ran over to check it. No,
It's
yeah, I'm
more
just
snow.
curious. Allison, I'm familiar with Block Island, a fellow Rhode Islander, and also familiar with Mary Donnelly. I have worked in Rhode Island as a public health nurse for a really long time, so Mary's well known to those of us here. But I'm just curious if you would talk us through a little bit about like how did you find out what it was that the community needed? Like what did it look like when you were gathering that information?
Yeah, it's a great question. I think it really took many forms. So maybe like many Rhode Islanders, Block Islanders are not shy telling you what it is that they want and what they need. But we did a lot of listening in sessions. Like, for example, we would go to the senior advisory committee and hear about what they thought, how they defined aging in place on Block Island. What did that look like for them? What would be kind of their ideal? And then we had people calling us up and talking to us all the time. So we did a lot of that. And we also hosted a couple talks like at our local library, just getting people involved in that conversation of what it means to be rural, kind of some of the things that are some barriers that we encounter just because of our geographic isolation. So it was kind of sporadic, and it took a long time to kind of condense all that and distill all that.
Great, thanks.
I think that's so important. Were there any like key data points, Allison, as you were going through and looking that the community really needed to understand for like a baseline, just like knowledge that then about primary care in your community?
So I'll want to answer your question with like a very brief story. So when we kind of run numbers about sustainability and how we kind of stay open and all of those things, we did this big study where we compare kind of our urgent care side of our business and our primary care side of our business. You might imagine, like, because we're a tourist destination, our urgent care is pretty sporadic, because it's like, oops, I fell off, whatever this thing is, and I'm on vacation. And that was not part of the plan. So we have lots of people who are non-par, underinsured. No one plans to get hurt or sick on vacation. So we had a lot of kind of uncollected balances, and it was really challenging for us. And we went to the community to try to say, hey guys, listen, like, look at this problem. Non-participating, sorry. Thank you, John. And the response we got was, do not take away our urgent care. So we came to try to make this case with data about our own sustainability. And the message we got from the community was, we rely on you for this, and we are scared that you might take this away. And so we knew that had to be part of our plan. It had to be part of our plan kind of no matter what. The island depends on us that way. So in a way that sort of answers your question, but it tells you like we have to balance what our community wants, even if it's kind of not against, but is not exactly in line with what we think would be best, I suppose.
Yeah, your ROI might be a little upside down, but you have to do it, right? Because
Yeah.
of that community need. So I've seen a couple of times people are curious about your scalability in the summertime. Obviously, huge influx in the summer. How do you sort of meet that need?
We work really hard. We stretch really thin. We bring in some ancillary help at like the front desk position, and we bring in some summer college kids who want to be nurses or doctors, and they help us out. We scale up our EM residents at that time of the year, but we don't add other providers.
Okay. One question, I'm going to combine a couple of questions here, which is we talk about building community in this process, right? And we talk about utilizing some of the different community organizations or things that, it's not just you as a standalone, you need some of these other pieces. So between what other organizations do you partner with, and included in that, like grant processes, which sort of go hand in hand, maybe in my brain, but maybe not.
So in our local community, it's everybody. So anybody from having conversations with the school about how we can be a partner there through things like, dental programs and behavioral health for adolescents, to our EMS team, who's all volunteer, and they work incredibly hard in the summer and all year round. But in the summer, it's a real slog. So trying to figure out how we can better support them and what things need to be in place to make their lives easier, for sure. And then partners like the Coast Guard, who come and pick people up when there is no other option. Trying to work even on those workflows, which are pretty set, but what else can we do? For example, if you can't land at the airport, can you land at the northern tip of the island? And what would we have to do to make that happen? And just like all these little things that you don't necessarily think of in those types of situations. So it really did and does take everybody.
And then with that, how does the faith community sort of come together? Because as far as I've known or seen, there are no synagogues or mosques on Block Island. So, um, how do you partner with people there?
Yeah, I mean, we have small faith communities, but our faith communities are very much involved in um, doling out kind of help to the community in different ways. You know, the Harbor Church, for example, which is right downtown, it's kind of our biggest structure. They have a food pantry in the basement, right? So their Helping Hands is in that uh, area. They also like host our international students. So we partner in these kind of different ways where we'll speak to a group of international students who are gathered about what the medical center can do for them, and Helping Hands hand out flyers during COVID, masks, whatever, bring WIC there. So it is, you have to be creative, but I guess the benefit of a small community is you know all the players, which is very helpful.
So Pat Tokars actually asked a question somewhat similar to that, and maybe we'll wrap up on this. Pat, are you still there? Are you able to sort of um, ask your question about the work groups and sort of what you were looking for information on?
Sure, thank you so much. This has just been inspiring. And I love the concept of telling the story as a way of building the community and making everybody feel a part of this. But who is actually on, what is the actual group that sort of over the years keeps working on this and getting this done and pulling all these pieces together and applying for grants? Who's on this organization? What sustains it? And have you become sustainable yet, or is this whole process still dependent on grants at this stage?
Great question. So the work group, it's a very formal name for what we do. You know, I think we're a small place. We're super flexible. We use everybody that we can to the full scope of what they can do. So you work at the front desk, but you got some interest in grant writing. Hey, come on up, you know, whatever it is. So we have a great board. We work with our board very closely to identify grant opportunities. We also have a great relationship with the Office of Primary Care and Rural Health in Rhode Island. So we always kind of go back and forth with them to see if we can get a little help here or there. In terms of what sustains us, we are mostly grant funded. I mean, not grant funded, donor funded. And also we get funding from the town. So we're kind of 1/3, 1/3, 1/3 at this point. Our operating revenue, our grant, what we bring in for donors, and then our grant that we receive from the town of New Shoreham. So we have not reached a place where I feel like we're very comfortably sustainable. Every year is a little bit of a, let's see what we can do here. And thank goodness for the people who donate money every year to keep us going.
Thank you.
Well, thank you, Allison, so much. I think that's all we have time for questions. I'm actually going to pass it over to Michael Fine.
Thanks, Patty, and thanks, Allison. I think now everybody can see why when I heard Allison speak, I so much wanted her to speak here. Because that ability to tell a community story is so critical to help communities see themselves as able and capable to provide primary care to everybody. And just by the by, when your work group is ready to become a primary care for all Americans work group, we will be right there, thrilled about including you in that way. As everybody knows, the news out of Washington is pretty confusing. The good news is that everybody now seems to agree the United States has a problem with healthcare and with chronic disease. The bad news is that our friends and colleagues in Washington haven't yet figured out that the way to fix this mess is to provide primary care to everybody. But what they can't do in DC, we can do in our states and communities by working together, by building local and state work groups, which we can do and you can do by reaching out to just one other person and getting started. So let's get this done because there's no one else to do it for us. I had the opportunity to be in New Bedford yesterday to work with a subgroup of the Primary Care for All Americans working group there. And as I was walking around the community, I saw a little description of the role that Frederick Douglass had in the abolitionist movement, which really was very important to New Bedford itself. And I read the story that there was once, I think, a church with a big Liberty Bell that was really important for the abolitionist folks. And then I think the church burned down and the bell got messed up. So what they did was they melted the bell down and made thousands of little bells, which they gave out to other people to spread the abolitionist movement around. And that's what I see in this group. That's what I see in all of you. You are all those little bells spreading this movement from person to person and place to place. I don't know how to thank you all enough, to Allison, to Alan, to everybody who participates, to Patty. This thing is happening. And the challenge is to make it happen more and better by talking to one another and by bringing other people to the table.
So thank you, Michael. I want to take a couple of minutes to just thank everyone for joining us. Let's continue growing and make a difference together. Please mark your calendars as our next Zoom meeting is on February 25th, when we will be discussing how to use the Primary Care for All Americans local playbook to organize in your community. We look forward to seeing you there. If you've not seen the playbook, check it out in your email in the next 2 weeks or go to our website and share that with your friends and colleagues. Please register on our website, www.primarycareforallamericans.org. And while you're there, click on volunteer. Contact us. We need your help in any way we can. Please donate and support us. And if you'll indulge in me for one moment, I am a proud board member and one of the founding board members of Primary Care for All Americans. On behalf of the board, I do want to thank everyone for their support and dedication in building this grassroots movement to provide primary care for everyone in America. We are building a healthcare system that is for people and not for profit, and it's starting by providing advanced primary care to every American in every neighborhood and every community, including Block Island. So by including all Americans, we will improve the public health of our nation, we will lower costs, and we will help strengthen our democracy. We have developed a tremendous momentum, but we need your help to get to the next stage. We are getting tremendous support from many of the national organizations that are supporting primary care. In the last 2 years, we have accomplished a lot, but we need your help. We have grown tremendously, but there is so much more we could do. To get to the next level, we need to hire a full-time executive director. We can't do that with part-time donations and intermittent grants. We need support from everyone. So if you believe in our movement, and hopefully you all do, donate what you can on a monthly basis. I've done that. Whether you could give $5 a month, 25, 100 or more, 250, 10 million, we'll take it all. We need you to help us build this movement. We are on the cusp of doing something great. Every dollar helps us accomplish what we want. And together, we could create an amazing health system based on advanced primary care. I personally want to thank you for all of the support in joining these Zooms and everything else. So please take a minute to complete our survey. The link is in the chat. We want to hear from you. If you would like to talk to members of our leadership team, stay on the call when we're done, and board members for Primary Care for All Americans will stay on to hear your feedback. Thank you, everyone, and see you on February 25th. Thank you and good night.
Thank you, everyone.
We're going to be open to more questions or comments for a few minutes. If anybody's got other things they want to be they want to talk about or think about or have inspirations or ideas, things that we haven't done yet that we should do. This is a great time for us to talk about all that stuff.
Michael, I have a question for you.
Shoot, George.
So I read your book, Nature of Health, and I digested it actually. I really liked it a lot. And I keep using your definition of what health is because I think we've lost track of that. I'm curious though, it's almost 20 years old now. Unfortunately, your prescription for fix hasn't come to fruition just yet. I'm curious if you still stand by the tenets of your book, and then you still feel that's kind of the guiding principles for the work you're doing now with primary care for all Americans.
I think it really is. I mean, this is me personally now, but if we understand that health is about the ability to function in community, then the challenge is to build and strengthen those communities. And I think this work is exactly a continuation of those ideas. Because, the thing you don't want to see is the ability of communities to take care of themselves kind of drift away.
Mm-hmm.
We have the ability to bring something to communities that communities haven't seen for themselves. I mean, think of how communities provide police and fire protection and provide a bunch of other essential services. Mm-hmm. What I think we figured out is primary care is an essential service. We can use it to organize and strengthen communities, and that makes health meaningful because there's a community for people to have those relationships inside.
I really agree with that. I read a fascinating article in the Atlantic yesterday about how Americans aren't moving anymore, how we're not relocating, how we become stationary, and large the fact because we can't afford to do anything else. In the urban areas, you can't afford to move to the big urban areas anymore because the housing is just way out of sorts. But the smaller areas that have better housing don't have the jobs and opportunities. So it's got to affect our mission here to try to strengthen communities. Also, is the fact that we don't relocate like we used to, and you think that'd be a good thing because we could maintain the communities. But they actually said that when you relocate, you actually are more likely to reach out and make more connections because you're new to a community. So I think there's some demographics and some societal changes that bear on the work that we're doing.
But there's the opportunity to do a bunch of organizing work and take those people who aren't moving much and bring them together mm-hmm. to work on a shared problem, which is meaningful, intelligent healthcare, which starts with primary care. Mm-hmm. George.
Yeah, thanks. And Allison, thank you. Let me just lower my hand here. And thanks to everybody here. It's very, very gratifying to be doing something that's positive and not negative. So I thank you for that. Allison, I had a question about, I'm sure you're aware that primary care has been just been getting hit by a lot of adverse trends and is under siege and having trouble making a go of it. One of the ways in which some primary care organizations are trying to bring more resources to the table is by giving patients their own data and their own remote patient monitoring devices, other tools, health coaching, health coordinators, navigators, and you can call these force multipliers if you want. And I'm interested whether or not your group has tried to get involved in those kinds of newer ways to help patients get involved in and engaged in their own care. A lot of people say, "Oh, it's very hard to engage patients in their care." We've had success doing that, and it's a complicated subject. It involves meeting people where they are and a lot of other things. But I'd just be interested in your experience with that set of trends that are going on out there. Thank you.
Yeah, thanks for the question. We have not really dug into this as much as we would like. We have a couple things on the horizon that might set us up for some success in that area, specifically a DNP student who's looking to do group visits in our clinic as part of her project to look at kind of more of a coaching model for overall wellness. So that's kind of interesting. We want to support her in that and kind of see how it lands within our practice. We've kind of dabbled in more like care navigation with mixed success. So I think what we run into in our community is anytime we try to outsource that to somebody who's not on island or isn't familiar to our community, it's not as well received or as effective. Because the first kind of comment is always like, why are you calling me? So they have to be integrated in the community and in our facility, which has been a struggle with our kind of our staffing and our budget, but certainly things that we would love to dig into.
Great, thank you. And another question is telehealth. Do you use telehealth video conferencing with patients on the island so they can stay at home? They don't have to, if they're elderly or infirm or whatever. That's part of the suite of things that are, not just coming down the pipe, but that are here. And there are pros and cons to it, but used judiciously and well, it can be a big help to patients. It's efficient, it's convenient, it's lower cost. You can get a lot done. So any thoughts on that?
Yeah, we absolutely use telehealth. We use it for patients who would like to stay at home, but we also will send providers to people's homes if they
Right,
would like
right.
to not come in.
Yeah.
So that's been really great, and we're experimenting with that. We also, our behavioral health program is probably the place where we most utilize telehealth. And I'd like to see us lean into that a little bit more for different specialists who would be on board for that. For patients even to be able to come up to the medical center and use our space as kind of a home base for conferencing with specialists on the mainland whenever possible.
Yeah. Thank you.
Liana, did you have a comment? You're on mute.
Sorry. It's just something I stumbled on today in another situation, but I thought it might actually be useful to people who are starting to do things. The Rhode Island Commerce, it has a current grant available it's a matching grant up to $25,000 for equipment for different kinds of businesses. Obviously, the organization is nonprofit, it's not buying equipment. But a place like this that might want to need to buy stuff for the telehealth, they have rules. I put the link in, it's kind of tangled up looking. You have to put all of the stuff into the box to get the Rhode Island Commerce thing. But the deadline is March 20 something. So you have a little while. And
Thank you.
I think it could be useful. And my experience with Rhode Island Commerce back during pandemic is they were very helpful. I got rejected the first time I applied for something. And when I called them up and said, I think you don't understand why this is relevant, they worked with me and we did get the funding. So they're not like, they mean to help.
Great information. Thank you. Anybody else? Going once, going twice?
I do have a very silly question.
No such thing.
So obviously in healthcare, we use terms and they are sometimes vague in their definition. How would you define advanced primary care? How does that differ from like DPC or concierge medicine? And what is kind of a price point that people should expect to pay for?
I'm going to take that one away.
Did you say me, Michael?
Yes, you're the advanced primary care.
Advanced primary care really has nothing to do with how it's paid for. It could be paid for in any way. So it's not about the payment system. It's about what you're offering. And it's about a comprehensive service. I kind of look at like like at the onion peel kind of way of looking. In the center is the patient, and then it was the traditional patient and provider. And then we added like nursing staff, and then we added social service and case management and pharmaceutical people helping. And then we started looking at this as the whole person. What causes disease? How do we look at prevention, lifestyle medicine, nutrition, exercise? Stop chasing chronic complex illness and let's prevent it by, preventing obesity, and by doing that, preventing diabetes and high blood pressure leading to heart attacks and strokes, and making sure we have a comprehensive system that deals with prevention. So, it's about, I hate to say the one shop stopping kind of thing, but it's about everyone having a primary care physician that meets every need of comprehensive and continuous and compassionate care. We call it the C's. And includes things thinking outside the box. How do we deal with health-related social needs and spiritual needs and everything that makes someone a whole person as a human? One of our board members, Dr. Wayne Jonas, certainly one of my mentors and heroes, looking at this as the comprehensiveness model. And comprehensive doesn't necessarily mean you do every single procedure or whatever it may be, but it's about taking care of the whole person, being the quarterback of their care and delivering it where they need it and when they need it, and being accessible to all and affordable to all, but
Got it.
not about the payment way. So a
No,
direct primary care practice could do that. A hospital-based extension clinic could do it. A community-based health center could do it.
got it. So in terms of price point, what would something look like if we were doing this within our community?
Again, that would depend on the payment model. So where I work, we're delivering that kind of care, but we're able to do it because the vast majority of our patients are Medicaid, and we're globally capitated. So we are incentivized to deliver advanced primary care to keep people well, keep them out of the hospital, do care management. And we've shown great success in my program. We have a 22% reduction in ER visits. We have a 25% reduction in hospital days. And we are continuing those numbers in year 5 now, and looking to improve now by adding some integrative kinds of models. Group visits were talked about on this call. Group visits are a huge component in dealing with people with, certain medical conditions, but also dealing with people with lifestyle, wellness, health, meditation, yoga, things that keep people well and healthy and off 9 million medications, but especially out of the hospital, out of the ER, out of the high cost centers, and away from specialists that are just looking to, for the most part, I'm not saying all, run up bills and do procedures that we know a half to the third of the time are simply not necessary.
Thank you for that, Alan.
Thank
Can I
you.
just jump in if I had to guess? My guess would be that the per person per month cost of that kind of primary care is between $100 and $150 per person per month. And that is in comparison to the average primary care cost across the nation, which is between $500 and $600 per year. So it's more than we're paying now, but that's a tiny fraction of the $15,000 per person per year we pay on average for healthcare in the United States.
And it's kind of what we're asking for. Right now, 5% of the healthcare dollars is spent on primary care. If we could double that, that meets Michael's numbers that he just said by doubling it. And in the long run, we're going to decrease the cost by keeping people out of the hospital, out of the ER, not having heart attacks and strokes, preventing cancer, preventing chronic complex illness rather than treating it.
Gotcha. Thank you.
I know we're comparing apples and oranges here, but I have a DPC doc here in the Indianapolis area, and he $70 a month for unlimited visits, free lesion removals. My medications, I have 3 of them. They're inexpensive. They're $20 for a 3-month supply. So there are ways to deliver primary care outside the current model that makes sense. Now, DPC doesn't make sense for entire communities. And we don't have the docs to go around for that. And I think, Michael, what you're referring to is the total cost, not including hospitalization. I still have to have Medicare, for the hospitalization end of things. But some people think DPC or concierge medicine are the same thing. They're not. And there's a lot of affordable DPC out there.
So what are we looking at panel size
About 400, 500 patients.
on DPC or advanced primary care?
DPC. Again, advanced primary care encompasses a lot more than just DPC.
I've recently figured out that panel size means how many people one doctor cares for.
Yes.
And I think DPC is
One provider.
direct provided care, direct primary.
Direct primary care.
So,
Yeah.
and
And
there
I was
are,
just asking about the advanced primary care. What type of panel do you typically have with that?
sense.
Well, again, I think advanced primary care is a more of a total term for care that's given in a more comprehensive fashion. But I don't think anybody calls themselves an advanced primary care physician.
No, I agree with that. And in our model, it's love it to be 500. It's not, we couldn't survive that way as an institution. It's more like 1,200. But again, it's not a single provider in a community practice where we work. Each one of our doctors has a full-time medical assistant. Each one of our doctors has a full-time navigator and part-time nurse and social worker. So we're delivering a team-based care. So in the direct primary care model, it's hard to do that because you can't afford to pay for those 5 ancillary people that we're covering. So that's why our doctors are able to deliver like a direct primary care model, having more like 12 or 1,400 patients because we're doing it in a team-based model, unlike direct primary care.
But
Sense.
let me just mention that one of one of our focuses in primary care for all Americans is to think about workforce, because there's plenty of evidence that suggests the average panel size, the number of people each clinician can take care of has dropped considerably over the last 20 or 30 years. When Josh and I were in active practice, I think we probably both took care of 3,000 people each, something like that. Today, that's probably the work of 3 to 6 people. Things have changed in terms of the electronic medical record and guidelines, and new medications. So the number of people each clinician can take care of is dropping, and dropping pretty quickly, which means that we have to have a real focus on workforce. We probably need to quadruple the primary care workforce. And that's probably the subject of a different evening. But we need many, many more medical schools and residencies, and nurse practitioner schools and PA schools and nurse practitioner residencies and PA residencies if we're going to meet the nation's needs. And that's one of the things that the state work groups are very focused on, and actually something that local work groups can begin to get involved with as well. Allison, I don't know if you guys on Block Island have thought about developing scholarships so that students from Block Island could go to nursing school or medical school for free, but have an obligation to come back and practice on Block Island. That's an old model from the National Health Service Corps that has really shrunk, but it's one that has great potential if these kinds of scholarships are offered by both communities and by states.
We
Yeah.
have not gone down that road yet, but thank you.
Yeah, Michael, just picking up on that, and then I'll shut up. The thing that I was talking about earlier about getting patients head in their own care, and starting to do things with some of these telehealth services, using health coaches to help with things like behavioral health, not the actual delivery of the practice, but connecting to these, what we call health assistants. And that can be a health coach, it could be a coordinator, it could be social worker, connecting the patients to the right services at the right time in the community. So directories of virtual and community-based services that have been vetted. Excuse me, my cat is involved in this question too. there does seem to be a possibility to offload some of the lower level things that doctors have been trying to do for many years. And by that, I mean a lot of the uh, uh, data collection, data refinement, data analysis, guidance and documentation preparation. That can now be done by either lower level uh, workers and or systems that do these tasks. And so there's a move, there's a lot going on out there.
And lots of promising stuff. But
Yeah.
the challenge is to keep the focus on, not so much who does what or how we pay for it, but to keep the focus on making sure we get primary care to every single person.
Yeah.
That's
Yeah.
what we have not as a nation done, and where we need to really think about how to change health policy so people start to think like that. When we start to think like that, as Alan said, we'll get way better outcomes, way better public health at much lower costs.
Yeah, I'm with you.
Hey, George, how much do you charge for that CAT scan?
Nice response.
Nice.
But I do have a question about, Michael, or to the group, how do we get more primary care docs when you have the disparity between specialty salaries and primary care salaries? I had a wild idea is, how do we freeze specialist salaries so new graduates don't come out and expect to make, 3 times the amount of a primary care doc? Because until we change that incentive, how are we going to get more primary care docs?
Again, I'm interested to hear what other people think, but my sense is, scholarships with obligations. So you go to medical, if you're going to do primary care, you go to nursing or medical school for free, but then you have an obligation to practice in your own community.
Mm-hmm. Medical for free is an idea. Yeah, I like that idea.
I mean, I don't know how many people on this call did the National Health Service Corps, but I did. I went to medical school for free, and they even paid me $550 a month to live on. In my day, which is a long time ago, there were 1,800 of those scholarships a year. And so many primary care people were recruited by that process. Now there are 150 of those scholarships a year. And so what the federal government has stopped doing, the opportunity is for states and communities to start doing if they're going to make sure that everybody has primary care in their own community.
Yeah, and Greg, it's not just salaries, the salary differentials that are keeping potential doctors out of primary care. It's also that if you go around and talk to primary care doctors, they are getting hammered right now. They are not happy campers. Their work conditions are awful. So back to Michael's point about workflow and workforce, we've got to find a way that's why we're so interested in this sort of force multiplier. Is that a piece of the solution? And at some point, I'd like to talk to you all about it as a group. Maybe, one night we could do a presentation on that or a discussion about that.
We may reach out to you to sort of help you coordinate that if you don't mind.
Yeah.
But
no.
Greg, I think you said you're in Indiana. This is where we need people to start local work groups and state work groups, because this isn't going to happen by itself. It's going to happen when people kind of, roll up their sleeves and start working in their own communities. It takes one other person to get one of these little work groups started. We have lots of help and support, but what we really need is for people to jump in and get started.
Can I ask what the average income is nationwide for a primary care doctor?
About $250,000 a year, I think.
And where do you think that most primary care doctors would feel comfortable? Or is it a work condition thing in conjunction with how much they make?
Others?
It's both. It's both. I think so. But, I went to primary care and I practiced for 32 years because I love the relationships. I love the community. I love taking care of 5 generations of families. It was a beautiful way to practice. I never was burned out. I never felt burned out. But Michael, you're right. Near the end, when you have patient portals and you have, other ways that patients need to be engaged, you can't see as many patients as you used to. I delivered babies for 20 years. I mean, that's, you never see a primary care doc doing that now, but my gosh, talk about getting to know the families. And it was just beautiful.
The range is still, I mean, it's bigger than you think. When you look at concierge medicine, especially, I just finished working a consulting contract with a concierge practice in Grand Rapids, and a full panel for one of those providers, one of those physician providers, was 500 patients, but they're charging $4,000 a year, per patient. Now, a lot of that includes the diagnostics, advanced diagnostics that they're doing, but that's $2 million, for one physician, driving revenue in that practice. So that's kind of the high end of the primary care spectrum. And then, of course, it goes down from there. But even locally here, I'm in Kalamazoo, we have 3 independent, what I would call DPC docs that are not, working in the hospitals, in the 2 hospital systems, which owns all the rest of the primary care, other than the family health, the federally qualified health centers. And one is a family, an MD, family practitioner, DPC. One is a guy out of Chicago that's got a bunch of chiropractors in his practice. And then one is, interestingly enough, a nurse practitioner who's charging $200 a month, as a concierge medical practice. So, that's free enterprise in the, DPC and primary care world. That's not driving it to all Americans, per the vision of this group. But, when there is certainly money to be made in primary care.
Challenge is to find the folks who can advocate for expanding the workforce, for like quadrupling places in medical schools and quadrupling the number of residencies, medical schools and nursing schools, or nurse practitioner schools, so that we have the workforce, which we just do not have. And that's going to take a bunch of people in a bunch of states fixing it state by state. I think we're pretty much out of time.
No.
Thank you,
Thank you all.
guys.
We'll see you all on the 25th.
Good show.
Thank you all.
Thank you.
Thank you,
Take care.
Alan and Patty and everybody.